Hi class. My name is Christine. I am doing my major project on the history of really PeriAnesthesia nursing and recovery nursing, ambulatory care nursing, just because there wasn't a lot on specifically PeriAnesthesia. So I kind of tied a few things all together all in one with recovery room, outpatient surgery, how anesthesia evolved, and units in our past that I will go into. So I chose to dig a little deeper into the history and evolution of PeriAnesthesia and what all that entails, and touch a little bit on recovery room nursing, as well as outpatient nursing, because for me, it's a personal, I guess, specialty of mine, as you will, that I have found that I really enjoyed doing over the last 6+ years. So I decided to dig a little deeper and see kind of the backgrounds of how PeriAnesthesia, recovery, post-op nursing kind of evolved, and very interesting. So for those of you who do not understand, or maybe not too familiar with what PeriAnesthesia nursing is, in my personal experience, it is really caring for those patients and before they go to surgery, so preoperatively, and even if they're not going to the operating room, procedures. So with nurses who are consciously sedating them, so nurse conscious sedation is part of it. I have my husband helping me, so pardon me for any delays in this, but we just need to make sure it doesn't close on me. Sorry. So little side note here, again, it is preoperatively taking care of patients, right after they've received sedation or anesthesia and recovery, and then which is considered phase 1, or back in the day, recovery room, and then postoperatively phase 2. So either taking care of those patients that are going to specified units, like say they came from a surgical unit, they'd go back to the surgery unit, or if they had surgery on their heart, they'd go to a heart unit, those kind of things. Or as modernization has taken place, now we have the ambulatory surgery centers, which allows for outpatient surgeries to be done. So that has been my experience and practice in the last 6 to 7, almost 7 years, dealing in an outpatient setting. So let's get started. PeriAnesthesia nursing has many parts to it, like I said. Patients who have received sedation or anesthesia in the recovery or PACU, post-anesthesia care unit. It is the nurse caring for the patients prior to procedures or surgeries, and it's the nurse caring for those patients after their procedure or surgery in the recovery room, and to going home or going to those other units to eventually going home. So as critical care nursing states, that's a book written by Linda Urden, Kathy Stacy, and Mary Laughlin. PeriAnesthesia is really part of critical care nursing. It's defined as constant monitoring of complications, management, airway, treating pain, and assessing the patient for any signs and symptoms of complication from the surgery itself or sedation itself, which really covers a whole thing. So let's dig into the history. Over here, I have a picture of Florence Nightingale because she is pivotal to nursing, and we're going to get into why she is pivotal to the PeriAnesthesia nursing. So to understand PeriAnesthesia and how it evolved, I'll be highlighting the pieces of just the history to put it all together to hopefully make it understandable for you. So PeriAnesthesia has been around according to the American Association of PeriAnesthesia Nurses, also formerly known as ASPAN. There was early documentation in England in 1751 of a first recovery room. And since the beginning of that, thanks to Florence Nightingale, a legendary woman we've all heard of. She actually started those, segregating those who had received medications prior to even it being deemed anesthesia in separate rooms so that nurses could really focus on taking care of those. So what she was doing, in my eyes and in my experience, is triaging, and she didn't even know that. So you might have heard of Lady of the Lamp by her. This is an illustration to Florence Nightingale that the London News published, a picture of a woman gliding through a hospital ward of stricken soldiers holding a lamp in a war that was sparked only negative headlines about terrible conditions. So, as you know, there were many casualties during the war, and so that's really all we heard about was all these people dying despite interventions that we were using either surgically or medically. So, trying to like wrap their leg up or put, what am I trying to say? Help them relieve pain. What they were doing by home remedies, holistic care now that I think of nursing that they were doing back then because they didn't know much about it. So I incorporated that because that was the vision of what soldiers who were injured envisioned Florence Nightingale. And during the war, she would frequently visit those sites where they were injured. And according to her biography online, she would visit the sites where they were wounded and dying, not only in the hospitals, but in these camps. And this was the image that portrayed of her, like I said. She realized when visiting them that the soldiers needed to be separated based upon their injuries. And then as we headed into World War I, World War II, we still didn't know really why people were dying. There really wasn't anything really readily available with technology or medications that studied, people were just unfortunately left to die, as cruel as that sounds. But they did, in the later part of World War II, realize that immediately taking care of patients, so this is again another triage setting that they came up with, which relates to recovery room. They realized that if you take care of an injured soldier right away, so after their kind of buddy system that many soldiers had, so you and another partner, if your partner got injured, you would try to triage them, meaning if they say they got like a wound in their leg, you'd wrap their leg and then take them to these what are called MASH centers. So during the Korean War, these MASH units were established, MASH standing for mobile hospitals, basically, either on the land, in the air, through like helicopters, or on the ships. And these hospitals, the nurses and doctors were collaborative in order to provide the best care with surgical or other interventions. And they found out that caring for these soldiers immediately after they were taken care of by their buddy promoted better recovery and decrease in deaths. So the MASH units became nationally used in combats. And then in 2006, according to MASH units, they took down the last one and regained another name for it. And this is, in my eyes, really started, recovery room nursing with PeriAnesthesia, because you're triaging those who are sick, moving them on to what, once they get stabilized, onto a different part of there. And down here you can see that the system that they eventually used in the MASH system, labeling these patients, was color-coded. Black, meaning deceased or severely wounded. There was no longer hope for survival. red requiring immediate treatment in order to survive, and green, wounds or injuries that are completely disabling, referring to as walking wounded. So like maybe a bullet wound or a stab or something like that. So this system, as you know, also ties into how they label those in disasters, catastrophic events. So it's funny how them labeling patients in MASH units has carried over on into how we now label those in disasters. So funny. Not funny, but interesting in my experience. So it was then that the first recovery room in the United States at St. Mary's Hospital, which I have a picture here, was discovered in Rochester, Minnesota. So many of you are like, oh, Rochester, Minnesota, that's, rings a bell to me, because that is Mayo Clinic. So St. Mary's was, according to the online report at mayoclinic.org, 2017, the article of History of the Mayo Clinic, St. Mary's campus, was designed to be a place where the sick and injured came to, due to the Sisters of St. Francis and the mother of Alfred Mose being able to allow William Worrell Mayo, hence where Mayo Clinic came, and his sons to provide medical services. And that hospital opened with 27 beds and then expanded, as we now know, to that huge institution of the Mayo Clinic, allowing advanced practices we now know of to become there. So hospitals weren't, you have to remember in this time, not just, like I said, in a hospital setting that we think of like at a facility. They were on land with those MASH units. They were in air in the helicopters, on sea aboard the ships. So really, military nurses have paved a way for all these specialties to come into the future of nursing, to advancements, I guess. So from there, we go to that was really like 1950s, 1960s, sorry, when medical advancements continued and became kind of ordinary. So, and modernization with anesthetic medications were used. So the first use of medications to do procedures or surgeries was thought of by Crawford W. Long. So he used the ether and nitrous oxide that were put and given to patients to have them become unconscious. And so many more different procedures and surgeries were able to be performed because the patients were not awake and not aware of what was going on. So but what really wasn't studied was how the medication would affect these patients. So a lot of mortality rates because of ether was increasing. So they really realized that, whoa, people were having reactions to the anesthetic and not from, and complications from the anesthetic, not from surgery itself, if that makes sense. So they were able later to find out that these medications that had these such terrible effects really worked on the respiratory system, causing respiratory failure. And so they really wanted these PACUs or recovery rooms by OR to decrease mortality rate, according to the History of Anesthesia 2012. So it's crazy that realizing that medication created the recovery rooms to be close to the OR. And where I worked, we were just around the corner. PACU and recovery room was just around the corner from the main operating rooms, which were 4 to 5 operating rooms, depending on the day. So a little advancement in that really decreased mortality rate. The nurses were able to catch complications much earlier, and not to say that complications from surgery didn't happen, such as hemorrhage or bleeding. So this required then that more education needed to be done to the staff on the knowledge of post-anesthesia complications that grew in the later part of the 1950s into the later half of 1960s. Nurses gained knowledge really on-the-job training according to our textbook, The History of American Nursing, 2014. So, I mean, I think all of us can relate to this. Sometimes the best practices we learn are through trial and error on the job. And it's interesting that these nurses 50 years ago learned that as well. So continuing into today to better our practices and our care to our patients. The other issue was, so we all know and still feel today, the nursing shortage, which occurred after these wars because so many women were in charge of caring for, the injured and ill and soldiers off at war, that they became burnt out. So nurses needed to revamp the nursing shortage to be able to care for these patients in hospitals and these procedures and surgeries that were coming due to modernization with anesthesia and medications, and modernization in technology as that grew too. So heading into the 80s and 90s, the scope of perianesthesia practice was redefined to include ambulatory surgery nurses, which is awesome, realizing that, they didn't have to use medications such as, again, in the article, History of Anesthesia, propofol became Versed and fentanyl. Into the 90s, those were medications that didn't have to be used as much, and patients could still recover at home safely. So education programs then were adopted, research goals were then defined, certifications such as the BLS, ACLS, and CPR were then required according to the ASPAN website in the 80s and 90s to work in recovery rooms. So just making sure that the nurses were prepared to take care of these patients coming out of surgeries, procedures with sedation or anesthesia. Another thing that came about was called the Aldrete score, and basically that was a numerical score in the recovery rooms as technology was changing, a way to really assess the patient numerically to see if they were ready to go on to post-op or to go on to their specified unit. So for instance, if you were having a heart procedure done, you needed to give a report to the nurse on the cardiac floor. Were they ready? Were they ready to leave? Did they have enough time to recover? Were their vital signs stable? Things that were being assessed was their activity, so movement of extremities, nurses needing to assess that. Also, how are they breathing? How are they heavily breathing? Are they not breathing at all, apneic? Are they shallow breathing? And based upon those scores, you would tally that number in between a numerical score, 6, 7 being ready for or close to ready to go, to 10 being the most that you could get into these categories. Your patient was ready to go to post-op or to the unit. So really it advanced for nurses to know the phase of care that the patient was in. And in 1988, at St. Francis Hospital in Greensville, South Carolina, a group of nurses helped develop a modification for this for the outpatient surgery world. So this numerical system for assessing patients became a pivotal to the nursing diagnosis, evaluation of progress after surgery, and sedation, and interventions that nurses were able to use to help patients achieve the goals to post-op care. And this was all summarized in the article of Development of Post-Anesthesia Record Incorporating the Nurses, 1990. So again, as more advances were made into the 90s, modernization continued, procedures and surgeons advanced. The first ambulatory surgery center was established by two physicians, Wallace A. Reed, and this is the surgery center right down here in Arizona. It is said by the Ambulatory Surgery Care Association, which is another association that nurses can belong to, in an article to Where It All Began. These two physicians really wanted a change. Their thoughts were to decrease costs to not only patients, insurance companies, and also be safe about it. So sending patients home after these medications that could be life-threatening or have adverse effects, they still wanted to be sure that they had the criteria to have surgery and safely go home, and decrease using hospital space for people who could recover at home. So in today's current practices, there are more than over 5,300 ambulatory surgery centers. And I have a little picture up here just showing a surgical center and what it might look to get someone ready in the United States, which perform over 23 million surgeries annually, according to the American or Ambulatory Surgery Center 2017. And I just think it's important to know that, beyond the discovery that ether and nitrous oxide could be used to render patients who are unconscious during surgical procedures, the subsequent developments in specialties to reduce, mortality and morbidity associated with use, as we know, like I talked about, and then finding new medications really help the development of anesthesia as in a medical specialty, and is probably, perhaps in my eyes, the single most important improvement that enabled these advances in surgical specialties, and improved equipment as well, monitoring of the patients like we talked about, training, so not just on the job, but these actual educational programs within schools, and certifications that you need to work in a recovery room, and evaluations of patients by that Aldrete score, and then tailoring it to your facility, and the discovery of better anesthesia agents, like I talked about for SAD, fentanyl, propofol, are the main reasons why, ambulatory anesthesia remains in our modern time. So the development, too, of technology, like I talk about, and robotic surgery, for instance, just in my experience, are less invasive surgical techniques. And beyond that, I think I'm going to go off on a note and say that I think we're going to see more procedures being done outpatient. So I hope you have learned a little bit more about PeriAnesthesia nursing, why I love it so much, and the uniqueness about it. So I will just say, I think the most important thing, though, that we have to keep in our mind is, even though surgeries, procedures, care to the patients are not in the hospital, right? Patients don't have our knowledge of nursing behind them, or medical knowledge. So we have to remember to be sure that we are appropriately teaching patients and their families how to take care of themselves at home, because it can be such life-changing for patients, and really setting them up for success when they go home from these outpatient surgery centers is the thing I think we need to keep in mind too. And I think we do a great job, and I just think PeriAnesthesia nursing, to me, has really been exceptional to me, going on to, I'm now doing procedure sedation, and so I'm being able to sedate patients for their procedures, such as colonoscopies, endoscopies, pain procedures, and women's health procedures. So, like I said, I hope you enjoyed it. If you have any questions, let me know. Thanks. Bye-bye.